Hi, I am Dr. Syed Ahmed. I'm infectious diseases specialist, and today we are going to talk about Mrsa, skin and soft tissue infection and wound infections. We see a lot of patients who have more severe infection requiring IV antibiotics in the hospitalized setting. Uh, I would divide skin and soft tissue infection into two categories for the treatment purposes. One with skin and soft tissue infection and cellulitis without any open wound or without the breakdown of the skin, and the other category with cellulitis and with open wound. So patients with cellulitis without any open wound usually have no purulence and only redness and inflammation you will see, and most likely causes a streptococcus and a staph infection. Both of these infections usually treated with cefazolin or other cephalosporins. And if the patient is allergic to penicillin, then you can also use clindamycin. Clindamycin also covers a significant number of cases of community-acquired Mrsa. Second category is patients who have cellulitis along with an open wound infection. If the wound is open and chronic, then we will also see Mrsa or Pseudomonas in significant number of cases. Chronic wounds have a tendency to be colonized with these two aggressive organisms, and their treatment is necessary, sometimes with IV antibiotics. The IV choices for the Mrsa infection for patients who have cellulitis with open wounds is vancomycin, especially if the patient is septic. And if the patient is more stable and not septic, then you can also use clindamycin IV. For septic patients or for more severe infections, empiric therapy for Mrsa with vancomycin should be done unless the cultures do not grow any Mrsa. In that case, we can always de-escalate the antibiotics. If the patient is allergic to vancomycin or for any reason we cannot use vancomycin, such as in patients who have renal insufficiency and you need to avoid nephrotoxic agents, then daptomycin is another choice, although it's very expensive, and insurance companies don't like to use this antibiotic because of the cost. Linezolid is a third option, and is a bacteriostatic agent. Period. Other than linezolid, there are other options like ceftaroline. Then newer agents which have longer acting half-lives, such as delbavancin. Delbavancin half-life is about 14 days, which is 2 weeks, and only one injection is suffice. But the problem with delbavancin is once you give it an IV injection, then obviously it stays inside the system, and you cannot get rid of it, especially in patients who develop allergies. In those cases, then you will have to admit the patient to the hospital for a couple of weeks and use steroids, Benadryl, and other antihistamines, etc. Delbavancin has the good thing about the delbavancin is you can use it as a single injection in the emergency department and discharge the patient. Other antibiotics which are newer agents and have longer acting half-life are oritavancin and telavancin. Oritavancin has a half-life of about 10 days, while telavancin is usually given daily. Now let's talk about Mrsa abscesses that present to the emergency department. If the Mrsa abscess, if you're suspecting Mrsa and the abscess is less than 2 centimeter, incision and drainage may be enough, and patient may not need antibiotic if the surrounding tissues do not have inflammation, redness, or cellulitis. For abscesses more than 2 centimeter, and if the Mrsa grows in the culture, then these are the cases where you can use antibiotics for 5 to 7 days. Sometimes extension of therapy to about 2 weeks is necessary in cases of more severe Mrsa infections. For Mrsa infection that's associated with bacteremia or septic embolization or secondary seeding into the internal organs, the treatment is longer therapy, more aggressive therapy, and I will discuss in my next upcoming lectures. Thank you for the listening to my lecture, and I'll be back again. Thanks.